because a lot of these diseases affect very young adults' ability to go to school, get married, have kids, have productive and meaningful lives. That's spectacular. It's progress we couldn't have envisioned decades ago.
Mm-hmm. Welcome to Self-Funded with Spencer, sponsored by Pareto Health, ClaimDoc, and PlanSight. Whether we're discussing innovative new healthcare strategies, exposing hidden revenue streams or misaligned incentives, or even just cheering on the next generation of this industry, we promise you that you're going to learn something. So thank you for joining us for another great conversation about the future of healthcare. So guys, real quick, we'll say hello and introduce yourself. Well, welcome to the podcast. I think I didn't mention it yesterday, Nathaniel, that the reason we're in this studio and not our normal studio is that we were dealing with bats, actual literal bats that were flying in and out of the old building, apparently. So they canceled my last two podcasts. We should be back in the studio Friday. So thanks for being flexible here. But for the folks that are actually watching on video, they'll go, where are they? We're in a backup studio right now. But I'm here with, I'm going to say it, Carolina Escobar, Dr. Yes. Escobar, and Dr. Oscar Bronsther. Did I get those both correct?
Yes.
And so Interlink is the parent company
Yes.
that you guys both work for, right?
Yes.
Okay, cool. Well, I think we position right now, this episode's going to be about cell and gene therapy predominantly, and I'm excited to cover this topic. But I'd like to get to know you guys both first, and so the audience can get to know you too as well. So why don't you start us, Carolina? Tell us a little bit about you, your bio, where you studied, and all those good things.
Okay. Well, so my name is Carolina. I am a physician. I'm a cellular therapy and transplant doctor. I have been clinical all my life. But I have been very interested in fact, education. So I always have been involved in activities educating the students, fellows, but also when these new therapies started, I became part of educational programs of these pharmaceuticals because I wanted the community also to have the information that we were receiving in the referral centers and what we were seeing in the clinical trials. So that part I loved. And then I got in contact with what the gaps of information, education, and health system were. But I got involved with Interlink because I became pretty much like a patient or an advocate to my children when they were born. And then I realized how little I understood from the system.
It's amazing, huh?
As a patient, I mean, I've been a doctor for more than 12 years, and I didn't know a lot of stuff that apparently I was dealing with. So I understood that. I knew that there were significant challenges, and I didn't understand even how people that didn't have my education were dealing with it.
Yeah.
So then I felt interested in being part of something bigger than my practice and something that will impact even more people that I was able to do in the hospital. And that's how I became part of Interlink as the medical director for the Symphony program.
Okay. And you started your interest in medicine when you were 13, right?
Yes.
Okay.
Yes.
What was that point? Why when you were a teenager, did you realize you wanted to be a doctor?
So my father is a dentist. He's an orthodontics, but his middle life crisis became like, I want to study Eastern medicine because he wanted to help people with other things.
Okay.
Interesting story. Other story.
Okay.
But then, I know about service and empathy and compassion, and he just put that on me. And then when I was 13, I think I said, I'm going to wear this pink dress today and what I need to do to cure cancer. And he said, you need to become a doctor. And I said, okay. And I never changed my mind.
Wow. So you literally committed that was going to be your life's path
Yes.
at 13. That's fascinating. And we'll come back to you because I want to give Oscar, Dr. Bronsther, an opportunity to speak. And real quick, give us some of your educational history and how you got into the world of medicine as well.
Our stories are similar. My father was a pediatric surgeon.
Okay.
And I did not go to medical school to be a doctor. I went to medical school to be a surgeon. I've actually been in the operating room since I'm 11 years old. My dad, many, many years ago, could bring people into the operating room to watch. You can't do that anymore. But I've been in the operating room intermittently since I'm 11 years old.
Oh, wow.
But I trained in general surgery. I spent a year in Boston working with Dr. Judah Folkman doing cancer research. Then decided I wanted to go into transplant, train with Dr. Starzl,
Okay.
who really was the leading transplant researcher, transplant surgeon in the world. Just recently died, over 90 years of age.
Oh, wow.
And then I went to the University of Rochester, where I was chief of transplant. My career continued to evolve. I focused on abdominal transplant and abdominal oncologic surgery.
Okay.
Did a lot of pancreatic surgery, did a lot of hepatobiliary surgery, operating on the liver and the bile ducts. And then over the last 7 or 8 years, I've migrated into industry because unfortunately I've had 14 or 16 orthopedic operations.
You personally?
Me, on my neck and my back. Some of that is congenital. Some of that was spending too many nights staring in awkward positions into the right upper quadrant of patients to do liver transplant.
Fair enough, yeah.
And I've had a lot of opportunities in industry. I've been working with Interlink now, it's hard to believe, but for 8 years.
Okay.
As their chief medical officer. I helped with other people to develop our cancer care product, which had started before I joined Interlink, but we continued to evolve during my tenure. We've expanded beyond the cancer care product now into a program we're calling Symphony, which incorporates cell and gene therapy, which is why we recruited Carolina, who has expertise in this area, to join us. And we're offering a product that we think hits a lot of pain points for insurance companies of cell and gene therapy, which I think we'll talk about, which is rare but enormously expensive. We integrate cancer care into that program. We integrate transplant. Interlink came to life almost 30 years ago offering transplant contracts, but now we're going to manage the transplant patients as well. We manage the cancer patients as well, and we've joined with a company called Renal Logic to offer end-stage renal care as well. So the Symphony program really hits, we think, 4 pain points for the insurance world: low frequency but very high cost problems. And there is a theme. It really makes sense if we get into it, why these 4 programs are all integrated into a single program.
Well, I certainly want to touch on that. And we're cancer care, we're big fans of at Pareto Health. Just literally yesterday, the folks that were joining me on the podcast brought up cancer care. They were in the consulting world, and so they love the product there. So I'm familiar.
Pareto Health is the largest benefits captive in the United States. With nearly 3,000 captive members, $1.3 billion of stop-loss premium in force, and almost 1 million covered lives, no other benefits captive comes close to Pareto Health's scale. But it's not just about the numbers. Pareto Health is a mission-driven organization, and that mission has 2 distinct parts. Number 1, to make self-insurance simple and more accessible for small to mid-sized employers. And number 2, to arm them with the most powerful cost management tools on the market. So if you're an employer frustrated with your healthcare outcomes, or you're a benefits consultant looking for an alternative to the status quo, it's time to consider Pareto Health. Pareto Health, where employers come to do self-insurance right, to do it easily, and to do it at scale.
We touch on that. I think we should start with the cell and gene therapy discussion, because I think that will make up a bulk of our conversation. And it's novel, it's relatively new, it's fascinating, it's scaring a lot of folks in the risk world that I exist in about what to do, how to pay for these things. And I would love to start at, if we could, out of an abundance of caution, describe what these things are for the folks that may have these are new terminologies for them. Let's define them. Let's sort of define the problem and then talk about how they work. So why don't you tell us even what is cell therapy, and then what is gene therapy, because those are 2 different things.
Correct. So we have diseases that they haven't responded to standard therapy. So we call them refractory.
Refractory, okay.
Most of them are cancers. We have other type of diseases that are rare diseases. The definition of rare disease in the U.S. is a disease that affects less than 200,000 people. But there are multiple of them. They're around in the 10,000 range. So when you take into consideration a rare disease, but you lump them together, it's 10% of our population.
And these are the diseases that have been labeled orphan diseases, correct? Where did that term come from? Do you know why are they labeled orphan diseases? Is it just the rarity of them?
The rarity of it, and because they are so rare, there is not sometimes a standard of care, or there is not an actual treatment that you can offer. So a lot of them will have support therapies, but not like a cure.
Okay.
And the other thing is that because they are so rare, there is not a lot of support regarding research, or let's say 20, 40, 50 years ago. So gene and cell therapy come as a solution to this type of diseases that don't respond to what we have available right now, or diseases that nobody knows that they exist or that they impact a small percentage of people.
Okay.
What is cellular therapy? So what you do with cellular therapy is that with cells, you will replace cells that are not working anymore.
Okay.
An example of that is a stem cell transplant, where let's say we have a patient with leukemia, we have to replace those stem cells that are sick. We eradicate them with chemotherapy, and we replace them with the stem cells from a healthy donor.
Okay.
That is cellular therapy.
That is cellular therapy. Okay.
Another example of cellular therapy is not necessarily replacing, but you are potentiating the effect of a cell. So think about the immune system. You have a patient with lymphoma. The immune system is fighting the disease, and what you're going to do is provide them with CAR T. That is, the definition is chimeric antigen receptor. So what you're doing is removing a subgroup of that immune system.
Okay.
You're going to send them to boot camp. You train them. You make them snipers against
okay.
that specific cancer cell. That is a CAR T.
That's a CAR T.
And then you infuse them back again.
Okay.
So you're not replacing the immune system, but you are
Training them
helping
up.
them
Yes.
with a very highly trained
Okay.
subgroup of snipers.
Okay. Yeah.
That is cellular
That's
therapy.
cellular therapy. Okay.
Gene therapy. You had a question?
No, I was gonna
Okay.
follow. I wanted to make sure I sort of positioned and quantified this, and I wanted to track your statistics. An orphan condition or disease is anything that affects less than 200,000 people. Is that in the world or in the United States?
It is definition in the United States.
In the United States, okay. But contextually, you said there's so many of these type of diseases that it actually does collectively affect 10% of the population.
Correct.
Wow. And then I think, Oscar, over coffee, you're saying there's plenty of these diseases that we almost haven't even uncovered yet.
It's ironic, but we're identifying 500 to 800 new orphan diseases every year as we continue to explore the human genome.
Okay.
As we start to identify other alterations in patients' genetics and realize that this alteration causes a disease state, and then we identify up to 200,000, but frequently it's 20, 40, 60,
really rare.
200 kids, primarily kids,
Okay.
who have this mutation, who have this specifically defined medical problem.
Okay.
And then we have another orphan disease that we've just identified.
So these diseases may have existed throughout history. We just have not identified them prior
Because they're so rare.
because they're so rare, and because we normally wouldn't detect them, or we would associate them with another category of
We
disease.
didn't have any way to understand the similarity or what caused
Okay.
these very unusual conditions.
I see.
Now when we have a child who has really unexplained problems, we'll frequently study their DNA, identify what the problem is, and then search for what this means. You find 27 kids in the literature or in the world with similar problems, and as I say, you have another orphan disease.
Okay.
So we have somewhere between 7,000 and 10,000 recognized orphan diseases now, but the list grows every year.
Okay.
And even prenatal screening has changed. Because for those genetic mutations that Oscar is talking about, at the beginning, you had a couple of genes that you were able to determine. But now that prenatal screen grows higher and higher. So even before they're born, you know that there's an alteration, a potential mutation that will cause a disease.
Okay.
And talking about gene therapy,
Yes.
because gene therapy is more targeted to these type of diseases. So around 80% of these rare conditions will be caused by one genetic mutation.
Okay.
So when you have a disease that is multifactorial, it's really hard to cure. But when you have only one gene that is mutated and is the one causing all those symptoms or signs that the child has, then gene therapy becomes the opportunity to cure that disease. Because what they do is that a deletion or a abnormality can be removed and replaced with DNA information that will allow that cell to act normal.
Well, you said you use the terms like this is almost like Star Trek.
Star Wars.
Cool
Star
sci-fi.
Wars, okay.
Yes.
it's just you describing it. Even you're describing it in a way that I think everybody can understand or follow. The way that you're describing it just seems so mind-blowing to me. So part of me goes, this technology is just fascinating. The other part of me that deals with the risk and the financing of the risk goes, it's terrifying, the price tags of some of these drugs. So really quickly, could we quantify the impact of some of the more popular or more prominent gene therapies? What sort of price tags we're seeing associated with these things?
Well, so for instance, one of the most exciting opportunities we have now is to treat young adults with sickle cell disease.
Okay.
And interestingly, in the last year, not one, but 2 different gene products were approved by the FDA to treat patients with sickle cell disease. Only about 20 or 25% of the sickle cell community are suitable candidates for gene therapy.
Okay.
But that's still tens of thousands of young adults and children. But one of the product costs $2 million. The other product costs over $3 million.
Okay.
It's actually, I think, 2.2 and 3.1 million.
Rounding errors at this point.
Yes.
And that is what the gene product costs. These genes are administered as an inpatient, and then you may have another $1 million+ of hospital costs attached. So to get a gene treatment for your sickle cell disease may be billed at $4 or $5 million.
Well, wasn't there one this year? This is 2024. I believe this podcast will come out before the end of the year. But wasn't there one that was approved with a $4.25 million? Which one is that?
It's called Len-Mel-D.
Okay.
It is for a very rare condition. It's called metachromatic leukodystrophy.
Okay. Okay. And so that one has a $4.25 million price tag, I believe. And you say
I am a very sophisticated physician. I've never heard of that.
Yeah, I think
Me neither until I started it.
I saw your brain go, I cannot remember the name of this thing. And that even for challenging for you, I know
That's how rare some of these things are.
Yeah.
Yeah, and do you know, when you say rare, we're talking about these all are relatively rare, but this is extremely rare, this particular condition?
They are.
Okay.
And the thing is that when you are diagnosed with a rare condition, it's not that you're going to see the doctor that is in your community. You always are going to be to a referral center.
Okay.
So even for physicians, these diseases can be completely unknown because they have a special center where the special and multidisciplinary team always deals with this type of population. So this is as uncommon to you as it is for me. I have never seen a patient with that diagnosis.
But it is interesting. So doctors no longer just order blood tests or x-rays. They're now starting to order on a semi-regular basis when they have patients who have unexplained problems. Well, let's study their DNA.
Okay.
Let's see if we can identify a genetic explanation for these symptoms I've never seen before.
Okay. And so now we're detecting them more regularly.
Right.
I think I was telling you guys over coffee, these still seem relatively rare to us, even with 1 million+ lives in our population at Pareto. I think we saw a handful 2 years ago. I don't think 2023 is fully closed yet. I suspect it's in a similar range of lack of frequency, but that's now. I think everybody's bracing for the higher frequency or more of a prevalence of this in the future. And so then we're trying to figure out how to pay for them, which I don't think we need to spend too much time on this podcast with that in particular, because I got 2 doctors here. We don't need to talk about the risk financing as much. But the fact of the matter is the whole industry is trying to figure out how to absorb and pay for the exposure here.
Especially because if I can make the point, right now we're talking about rare diseases and cancers that are refractory.
Okay.
But with the pipeline, we see that a lot of studies come for osteoarthritis, which probably we all will have it if we live long enough. Patients with Parkinson, diabetes type 1. So right now it's content, but I think with the diagnosis and how broader the application will be, this will become more a common treatment than for only rare diseases.
But we're not going to get economies of scale, I think is what you said. So like my brain thinks any normal marketplace, the more common something is, the more competition that results from the pursuit of these things, that the cost would come down. But realistically, the marketplace forces in healthcare probably won't allow for that. At least that's your opinion, right?
Yeah, but look, I mean, there are drugs that we introduced to treat cancer, some of the initial drugs we introduced 20 years ago, which are still patent protected or just coming off patent protection. 20 years later, the 3, 5, 8, 10 times more expensive than they were 20 years ago when it was first introduced.
Right.
So healthcare economics is a topic of a different discussion.
It is, yeah.
But they don't make sense.
Okay, fair enough. So let's talk about then the actual technology itself. And I think there's a couple different ways you guys said that we could introduce these corrected genes into a person. So why don't we talk about what would you call that, the delivery system itself? I'd love to understand that.
So for cellular therapy right now, we have approved by the FDA a product where you remove that subset of the immune system cells and they go to the lab where they get trained. And what I mean with train is that they're genetically modified.
Okay.
So they will have inserted a weapon that will only go for that target cell. So if you think about CAR T is like a hybrid between cellular therapy and gene because you are modifying those cells to become specialized in killing a specific cancer cell.
Okay.
That is all done in the lab. Once they have built that army, is sent back to the hospital where the patient receives chemotherapy.
Okay.
Not because the chemotherapy will kill the cancer, because we know that the cancer is refractory to therapy, but it's because your immune system is trained to kill everything that is not natural to your body.
Okay.
And those cells come looking a little bit different. So you have to suppress your immune system enough to allow that new, and allow them to do their job.
I see.
Because once they're infused, they're going for it. What Oscar was implying about the hospital stay is because all that reaction causes a lot of inflammation in the body. And that inflammation impacts normal organ function and tissues. So you have to be admitted to the hospital so we are able to control that inflammation response if it happens.
How long of a period of time would you be admitted then on
Usually
a normal
around
basis?
3 to 4 weeks.
3 to 4 weeks, okay, with 24/7 round the clock care.
And
okay.
sometimes it's an ICU bed.
Oh,
so obviously the cost is higher.
So that's where the $1 million price tag for the facility comes from.
Now,
And then we were talking about a delivery system that used a virus.
Right,
So
so-
explain that for me. Is that,
Yes.
maybe you're
So the point of this one is that you use your own cells, and right now in clinical trials, they are working on donor cells.
okay.
So there will be what we call on the shelf. So that will be a product that is a cellular therapy product, but it's a donor cell that will be infused. In the gene world, you can do that DNA modification through a vector. A vector is who is going to transport what is going to change in that DNA. And right now, the most common is a virus. The virus has the capacity to infect a cell, but that virus has been modified to not produce a disease. So we can use an adenovirus that produces colds, a lentivirus, an HIV virus. In fact, there are products that have HIV virus, herpes virus. So they are like alive, but sleeping.
Okay.
They're not going to cause any problems. They're just carrying that
So would dormant
information.
be the right word to use?
That's a perfect word.
Okay.
So they infect the cell. And that can be done ex vivo. That means that you have removed the cells and you modify them in the lab. Or interesting, you can transfer in vivo the virus to do it while they are in the body. So for example, a product called Luxturna, which is the first FDA gene therapy approved in 2017, they inject the vector inside the eye where they will impact the cells that need to be changed so the person doesn't lose their vision.
Wow. But wasn't there some problems that are introduced with that vector?
They were.
Okay.
Because the vector inserts the DNA randomly. So there was always a concern that if it is a random insertion, what can be activated in the DNA? And unfortunately, they have seen with some products cases of what we call MDS, that is myelodysplasia or acute myelogenous leukemia. There are problems of the bone marrow.
So essentially cancer then was created
Like
as a
secondary
result?
malignancy.
I think we have to look at all of these products, which are spectacular advances and are offering hope and cures to patients who previously were hopeless or incurable.
Sure.
But it's still very first, maybe early second generation products. There are side effects of CAR T. There are side effects, unintended side effects of a lot of the gene therapy. What we still hope but don't really know is that when we introduce genes to cure diseases, that lasts a lifetime. That's what we call a durable response. We don't really know that.
Yeah.
We're keeping our fingers crossed, and you can only justify these enormous costs if you've really cured a patient for the rest of his or her life.
Yes.
But we won't know that for 5, 10, 20 years. So, and again, some of these viral vectors, unfortunately, have been demonstrated to cause unintended cancers. Some of the CAR T cells cause unintended it cures one cancer and causes another.
Jeez. Okay.
So net, these are wonderful products. I'm not trying to frighten people.
Sure.
These are advances. But we're still very early.
Yeah, it's a nascent technology that we need to understand the risks that associated.
I am sure 20 or 30 years in the future, they're going to consider what we're doing now absolutely primitive.
Okay. But that's how it starts. We talked about the history of transplants.
Exactly.
Right? That's how it starts.
Exactly.
PlanSight is a complete game changer in the world of insurance brokering. As a broker, you know how time-consuming and error-prone the traditional RFP process can be. But what if I told you there's a better way? PlanSight is the only end-to-end RFP solution on the market made specifically for benefits agencies. It's like having a superpower that gets you an average of 8 to 10 hours back per employer renewal per year. And the best part? PlanSight supports all carriers, all funding types, and all group sizes for over 20 different benefits. If you're ready to make your RFP process faster, more efficient, and more profitable, it's time to call PlanSight. Visit plansight.com now to book a free demo and discover the future of insurance renewals.
So then what happens though, I think you said the vector of a virus was perhaps not as precise as we'd like it to be. Are there other delivery methods or vectors that we can use outside of a dormant virus?
Well, we're using a different approach.
Okay.
For the first time now, one of the gene therapies that we've approved for sickle cell disease uses technology called CRISPR technology.
CRISPR. Okay. Is that an acronym or what?
It is.
It
I don't
is.
remember what it stands
That's
for.
okay.
No, I don't.
I just assume you guys are both doctors. You
It's
know.
one of those
Every
things that you
question
read
is-
it.
CRISPR.
Yes.
Okay. Yes, I've seen that.
And
Yes.
I should know that.
Okay. Nathaniel, look up CRISPR technology for us and let us know. Okay. Keep going.
As I told you earlier, if we really get stumped, I can talk about the New York Jets. But
Yeah. But you're going to get it in there no matter what.
But CRISPR technology, which was awarded the Nobel Prize a year or two ago, is really remarkable because it's very precise. And using CRISPR technology, we can actually edit the DNA.
Okay.
The CRISPR technology can be directed to cut out specific parts of your DNA. And then we can also use that technology to introduce new parts of the DNA.
Okay.
And that doesn't use a virus to get into the cell, to get into the DNA to do that.
Okay.
So there are some problems with CRISPR. Even that's very early in the evolution. Sometimes it's not as targeted as we would hope it would be.
Okay.
But at least we don't have viral vectors. And really, we don't think we'll have the cancer complications
Okay.
from CRISPR that we have when we use a viral vector. That's correct.
Did you
isn't it?
find
Correct.
it? Like,
Yeah, so it's clustered, regularly interspaced, short palindromic repeats.
Okay.
I can't even repeat
Yeah.
that. Can you give me that real quick? Nathaniel's going to show up on camera for a second here. All right, so in case folks couldn't hear, so clustered, regularly interspaced, short palindromic repeats. I'm glad they use CRISPR as the acronym there. Jeez Louise. Okay, thanks, man. I appreciate that. So I didn't ask before. I want to go back a step. With that vector, let's take the example of the HIV, the dormant HIV virus. Is there the potential that that individual would then have HIV or contract AIDS? No. Okay. Because that seems, on first blush, you go, yikes, I'm not.
Yeah, I
that
don't want the
risk-
product.
That sounds risky. Okay. So there isn't the risk of that particular.
No.
Okay.
What you really need is a virus that very effectively gets into the DNA. You can't use a virus that just gets into the cell around the nucleus. You got to use a virus that actually not just gets into the cell, but gets into the nucleus, gets into the DNA.
Okay.
And different viruses are more or less effective in doing that. HIV is very effective in getting into the nucleus, getting into the DNA. But of course, we can manipulate these viruses So we don't give people HIV. So,
Okay.
So we don't give people.
Yeah, and that hasn't been reported.
Okay. Yeah, just the first blush, right? And so you have
Yes.
a reaction to that, and that seems like a little scary.
But to introduce an interesting topic,
Yes.
the adoption of some of these techniques or some of these opportunities isn't as robust as we thought it would be.
Sure.
And there is skepticism in the population about some of these products.
I understand that. I understand the skepticism.
Quite frankly, we're particularly concerned about the sickle cell products. We know the African American community, for many reasons, many of them very appropriate, is skeptical about so-called or supposed medical advances. So a lot of these folks are very skeptical or reluctant to take genetic manipulations. But the adoption of these opportunities is slower than we thought because of people hearing the HIV virus is going to be injected.
Well, and I was even just bringing this up because obviously the last couple of years we've been dealing with or understanding mRNA vaccines,
Right.
and whatever your opinion of those, that was a relatively new technology as a delivery system as well, and so there's skepticism with a large subset of the population from that. So I could understand not everybody's going to be an early adopter of something like this, and because they're so sufficiently rare, that narrows down the potential.
And some of the skepticism isn't crazy.
No, I agree with you. Yeah, that's what I'm saying. I think it's a healthy amount of skepticism.
I mean, we don't have 10, 20-year experience with a lot of these drugs or genetic manipulations they're offering people.
Well, some of them also come with trade-offs. There's one in particular, my understanding is I think you had to be male, under 25, you could never drink for the rest of your life, and you could be sexually active or something like that. I was sitting down with somebody that talks about gene therapies, and that was one of the particular ones. And maybe you aren't familiar with the one I'm talking about. I wish I could remember the name.
Carolina? I'm not sure.
But it was like once you narrowed down the potential candidates, there were other trade-offs for the individual to have to consider
Absolutely.
prior to receiving it, right? And so you just think, well, wow, that's going to be a really small potential candidacy pool after those things.
Some of those complications sound like deal breakers.
Yeah. Depending on your lifestyle.
And a diagnosis by itself doesn't make you a candidate for a gene or cell therapy.
Okay.
So there are specific indications, what type of genetic mutation. There are some exclusions criteria, but it also comes the clinical part. If you are not fit enough to receive the therapy or to survive the therapy, you should not be a candidate for it. So people need to have some type of normality of function of their kidney or their liver, something as simple as a caregiver. If a person lives 10 hours away from the referral center or where you're going to refer the patient and they don't have a caregiver, you can't take a patient through a process that is so complex. So the percentage, I think, of people, it will be even less compared to what it is only predicted by a diagnosis.
I see. And that's why you were saying over coffee that the real world application of these things, we're seeing a reduced efficacy versus the trial, the clinical trial version, because they were so specific on the criteria of selecting folks to participate in the trial. Is that my understanding of why we don't see the same outcomes necessarily as what was indicated in the trial?
I think that's more like a prediction because in medicine that usually happens. The clinical trials have this number of overall responses or complete remission. But in the real world, they tend to be a little bit different because there are multiple factors.
I see.
The social, even the religious, the philosophical, the physical. But the amount of people that have received these medications, especially gene therapy for rare diseases, as Oscar was saying, is a small amount. So you cannot extrapolate that information even for the clinical trials because the clinical trials will have 20 patients, 37 patients. So you can extrapolate that information
to the population level.
To everybody with different races, different ages, different medical problems as well.
I see.
So,
Except one of the problems when people are turned back into the community, properly trained follow-up, whether it's case managers or physicians, aren't routinely or necessarily available to them. Everyone will be meticulously followed up for 1 year or 3 years till they have the endpoints they need to get approval from the FDA, and then they'll be turned loose back into the community to some extent. one of the advantages that we offer at Interlink is we're committed to following these patients with specially trained case managers, specially trained physicians, Carolina and myself, and we have other people with us as well, to follow these patients on an indefinite basis. We think that we'll be able to offer these patients the same sort of meticulous follow-up that they received when they were trial subjects.
Okay.
So we really believe strongly that with the expertise that we have inside of Interlink, with the commitment we've made to the patients and to the insurers, that the patients we manage should do as well as absolutely possible.
Absolutely. Well, and so when you say in an indefinite basis, is there a presumption if we reach a certain point and they're still having the profound positive effects from receiving the gene therapy that we can say that was a successful case and we don't need to follow them? Or will it be throughout their lifetime potentially?
In cancer, we know when we can stop following people to some extent. Some cancers, it's 3 years. Some cancers, it's 5 years. Other cancers, for instance, breast cancer, we follow out to 10 years because you can have late recurrences with breast cancer. But you have a colon cancer, you're 3 years out, you have no evidence of cancer. Overwhelmingly, almost 90+%, you're cured.
Okay.
We don't know when we can stop following these patients who have gotten gene therapy. So right now we're committed to following them on an indefinite basis.
Is there the potential for the mutation to reoccur?
For various reasons, there's the potential, right, that the cure, the gene will stop replicating, that the disease will recur.
Okay.
Exactly how or why, maybe Carolina can explain better than I
So
can.
an example, when you were talking about what is the most expensive product in the market right now, in the clinical trials, they have 37 participants. At age 5, 85% of them, they have normal cognitive function, and they didn't require any motor assistance. At 6 years of age, that 85 was 58%. When you compare to what they have available, that was 0, then you say, well, it still is half of the population.
Sure.
But then I think time also will allow us to understand what subset of patients from a specific disease are the ones that really and truly will benefit from the therapy. That is right now something unknown. But to his point, it doesn't seem like it's the cure for everybody, or if it's going to be, which are those patients? What are the characteristics? What is what genetically is happening that will allow them to? But when you compare to the nature of the disease, these patients are doing very well, but not all of them.
Not all of them.
Some of the gene companies are talking about offering warranties or guarantees.
Yes.
And they'll guarantee that the gene will be effective for some predetermined amount of time. And if the patient relapses, they will reimburse some percentage of what the product cost or pay for the hospitalizations. I actually believe that the insurance community, at a minimum, should demand warranties or guarantees for these $2, $3, $4 million products. I mean, these drug companies, these gene companies have been refractory to negotiation. They've been holding firm on their price. Okay, at least right now that's okay, given how infrequent these gene procedures are. But if they're going to hold firm on their price, I really believe the insurance industry should insist on a warranty.
From the manufacturer? From
the manufacturer. You know, you're justifying the cost based upon what we would have spent to treat this disease over the lifetime of the patient.
Well, the hemophiliac example is a really good example, the macroeconomics of that.
Exactly.
You were saying that somebody who has hemophilia might be a $10 to $15 million patient over a lifetime because of the maintenance drugs they're taking.
Maintenance blood products.
Blood products, okay. So therefore, the trade-off, if the gene therapy was effective, might be what, $2 or $3 million. So those economics make sense if and only if there's durability that exists.
Correct.
If not, then they start to make a lot less sense. And so the warranty you're saying comes into play. At least somebody can warranty the outcome to a degree or a percentage of the outcome if it falls short of that durability.
And again, that's one of the services we're going to offer.
Okay.
I mean,
who provides the insurance then? If is the manufacturer purchasing insurance from a third party then?
Well, the manufacturer is just deriving all the income.
Okay. So they're essentially rebating or something?
Correct.
Okay.
And then what's really interesting, because the question is it the insurer or the reinsurer
Sure.
who's entitled to the rebate, right?
Well, in the self-underworld, I mean, the reinsurer is bearing the brunt of almost all of this,
Correct.
right? Oh, and they probably will reinsure above a different level, and then there's another party.
Correct. And then, of course, as you understand, if the gene product fails year 4, the patient may have an entirely different insurance
Exactly.
than what they had.
And they may not even be at the same employer.
Correct.
Yeah, at
So
that point,
we actually believe that whoever paid the bill is entitled to the rebate.
Okay.
So if the patient had insurance A when they got the product and has insurance B 4 years later, when the gene fails, it's insurer A.
Of course.
Who would
I would agree with that.
And we have the ability to follow that and make sure that happens inside of Interlink.
Yeah.
But these are all questions that everyone's asking, and we don't have the answers yet. But I think the insurance community ought to demand from the gene manufacturers this sort of
Seems
protection.
reasonable to me. Absolutely.
They're not
Especially
going to
with the price
negotiate
tag.
on the price, and they've been refractory to negotiations.
Yeah.
At the very least, they have to warranty, we think, their product.
Okay. And so what about the technology in itself? It sounds like it's constantly evolving and improving, not only expanding the orphan diseases that it would treat, but the precision within the delivery system is advancing as well. So what's happening in this moment? I know you keep track of these things. Like, what are some of the things that are new developments that are coming out in this space?
So they are working on make it less manual and less time intensive. To give you an idea, to create a CAR T can be anything between, depending on the product, between 3 to 6 weeks.
Okay.
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 But we are talking about patients that are refractory to therapy.
Yeah, can you explain refractory in this situation? Because I don't know if I follow what
So
that
for CAR Ts, let's talk about patients that have leukemia or lymphomas. So these are patients that have this diagnosis. They are standard chemotherapies, but you provide that chemotherapy and you don't see the lymphoma respond. That means shrink.
Okay.
You need these CAR Ts to be done faster, because sometimes you don't have a month with that patient because you have provided them everything that was available.
So they're terminal
and even like that.
potentially.
Correct.
Yeah, okay.
So that population, I think, will be more pro to utilize technology, because we're life and death, than a gene or rare disease that they have been dealing with it for years. For his example of sickle cell, and see, like, I want to watch how this goes first.
Yeah. Let
Because
somebody
they have
else
been
be the
doing- Yes.
guinea pig, if you will, quote
Exactly.
unquote. Yeah.
But when you have something that is the definition, like, is going to define if you're alive or dead, you probably will be like, well, what is the difference? It doesn't matter. So I think the CAR T history starts with malignancies for many reasons, but obviously the patients were more in favor of being just part of something that will provide them a solution. In the manufacturer, they're trying to standardize everything more.
Yes.
The reason for that is because every single time we require a CAR T, all the steps are repeated every single time. If they're able to standardize it, they can make it hopefully more cost effective, but also better for the patient to receive it. That's where the donor cells come, because they are available. You don't have to wait for them to be made. When he was talking about the bite therapy, is always identifying what is the part of a cancer cell that this technology can target.
Okay.
And because we know these don't cure all the diseases.
Well, I think we were talking about bite therapy over coffee, but I don't know if we mentioned it yet on the podcast. So can you explain what that is?
Yes. So with CAR T, you identify one thing from the cancer cell that you can target.
Okay.
The bite can have 2 or 3. And that's what they are working on.
Okay.
If identifying and targeting one piece is not enough to kill and cure everybody, how about I attack that cell through both fronts? There are bites that, in fact, they identify a target in the cancer cell, but they attach to they say a Navy SEAL, and then they say go, right?
Yeah.
So not only the target is in the cancer cell, but it's also targeting the immune system to say, there it is. It's hiding.
And
go for it.
And the bite cells will come off the shelf.
Oh, really?
The bite cells will be immediately available. You won't have to manipulate the patient's own cells. You can literally take the product off the shelf and virtually immediately after you've prepared the patient, infuse the cells.
How do they source those bite cells, then where do those come from? Well, if you say off the shelf, meaning
They're humanized.
they're human. Okay.
Yes.
Because it's interesting just understanding the source of all these things. It's not coming from the individual. Where is it coming from?
From a donor.
From a donor.
Yes.
Okay.
But the manufacturers right now have a lot of FDA requirements and also copyrights that they have to deal with.
Okay.
So I think that has limited also the process of standardizing and making it, let's say, the same process for all these amount of products or stuff like that. So
ClaimDoc is a medical claim auditing and member advocacy company. We provide fiduciary services to employer-sponsored benefit plans, and allowing them to create an environment where we ensure that the benefit plans are being charged in a fair and reasonable basis.
My business is basically people, and it become a real simple transition. We thought it was going to be far more complex. I've saved, we'll say, hundreds of thousands of dollars. I could not say enough about ClaimDoc.
So then where do you eventually see the future of this going? I mean, is it possible that we can not just cure orphan diseases, but there's all sorts of maybe minor mutations in our genetic code that we could go, oh, I've got this finger's not quite as long as the one on the other hand. Maybe I can make that longer, or, maybe I can get taller. I mean, do you think there's a potential for its far less severe states of disease that you could treat?
Well, as Carolina was saying, there's a lot of work being done in Parkinson's disease, in different kinds of arthritis, diabetes. Mm-hmm. So these are still serious diseases, but they aren't immediately life-threatening.
Yes.
Unfortunately, what you're talking about isn't impossible. I mean...
Well, there is a
may I get rid of some of my gray hair? Like, can I get rid of my gray hair possibly? Yeah.
I don't think right now.
Not yet. Okay.
Probably somebody's working on it.
I'm not doing a gene therapy to get rid of gray hair.
No, but I mean, we're not talking about this, but I mean, you combine the possible abuse of AI with our ability to manipulate DNA and some of these cybernetic monster opportunities.
Some like sci-fi dystopian world,
start to become not so sci-fi. I can't.
Yeah, sorry, I took us off track, but I was just thinking. My brain always thinks to where like, what is the logical ending?
This is a very good point about the Symphony program. Is that for me, probably because I like education and I find it that you are empowered when you know what you have, what are your options are, and that you can make a decision for yourself and your family, because most of these diseases will impact an entire family. You need to be educated in what is available, what is really the response, what has been the experience outside of clinical trials, what is the follow-up that I need. But if you're able to educate not only the medical teams, the beneficiary, the payers, then the understanding is what is going to empower us to continue implementing and adapting to these technologies. Medicine is not known to be this revolutionary, super fast like AI and technology. Medicine changes very slowly. And everything that has been new has required an adaptation and a time where we hate each other or we fight. My husband is an ENT, and he tells me the story about Dr. House that created the cochlear implant. That when he created it, it was for people to hear. But the community was outrageous how crazy he was that people even throw rocks at him at some point. There is like an implementation, a phase of understanding, educating what is hard about gene and cell, and you need a specialist and people that are just focused on it, is that everything is changing. So hopefully this podcast comes very soon because it will be completely not updated.
2 hours.
But look, I mean, we're getting far afield, but not that far afield.
Okay.
Medical ethics has to be taken very seriously. We have the ability scientifically to outstrip what we should be doing morally and ethically.
Agreed.
And we can't just move
just because
forward.
It can be done, it shouldn't.
We just can't move forward scientifically in pursuit of science necessarily without really understanding how it impacts society writ large.
Yes.
I mean, some of the work we're doing has the potential to bankrupt us, and some of the other potential of what we're doing has the potential to really change who and what we are.
Yes.
And we have to pay attention to this, and we're not paying enough attention to some of these challenges. We're not talking about that today, but you're right. When we start talking about the ability to manipulate DNA, that defines who and what we are as human beings,
Yeah.
that's scary.
Yeah, I couldn't
That's
possibly
scary.
agree with you more. And so, yes, I brought that up almost tongue in cheek, but I
No,
think it's
but
something that
you're
my
right.
brain wants to
It
think
is.
about is what do we look like as a species? If
No,
you will,
you're
in the
right.
future.
And a person will take in consideration their philosophical, their religious, their
Yes.
cultural beliefs
Yes.
to make decisions in their medical treatment, even now with things that are not so sci-fi.
Yeah.
So you have to respect those and understand them to be able to provide guide to a person of what is the right thing for them.
Well, so you mentioned education a moment ago, and I told you before we sat on camera that education is a big part of what I do for this podcast, is why I want to have these type of conversations to educate the marketplace. I want to dive into Symphony a little bit. So if I'm a listener, whether I'm a consultant or an employer or somebody that works in this space and wants to go, okay, how do I use it? Who's it for? When do I get started? How does it initiated? Let's talk a little brass tacks about the product, if you will. So let's start with the question of who's it for? Employers, correct? So do they have to be self-funded? Does it matter if they're self-funded or
matter.
not? Okay.
Doesn't matter.
And then what about a relative size of that employer would be appropriate?
Theoretically, it's targeted for groups above 1,000.
Okay.
Some of that is that we need a large enough population so that the resources we're bringing to bear will actually be accessed
Okay.
by somebody inside of that group.
Okay.
So the larger the group, the better.
The more
for us.
likely you can be useful.
The more likely,
Yeah.
the easier it will be to show value.
Sure.
Because somebody will have cancer, somebody will have a transplant, somebody
Yes.
might need cellular gene therapy, somebody's going to be on dialysis. So it becomes much easier for us to demonstrate our value. But we've really brought together 4 very low frequency, high cost
Yes.
offerings, combine them under a single umbrella. For instance, it turns out that if you have kidney disease, you're 4 to 5 times more likely to develop cancer.
Okay.
So there's an previously unrecognized or unappreciated relationship between
Yeah.
kidney failure, dialysis, and cancer. So there are medical facts that link all of these products together. Cell and gene therapy obviously primarily focus on cancer, they're not exclusively. So cell and gene therapy, very rare right now, but will year over year, decade over decade, dramatically increase.
Okay.
Our core product, which we've been offering now for a long time, is our cancer care product. Cancer impacts obviously a lot of people. And the older your population is, the more likely they are to have cancer. When you're looking at a young population in their 20s, 100 to 200 cancer diagnoses per 100,000 per year.
Okay.
When you're looking at a population, Medicare, over 2,000 cancers per 100,000 per year.
Okay.
So young people get cancer, and unfortunately, cancer in young people is increasing for reasons we don't fully
Right.
understand.
I've read that. Yeah.
It's increasing significantly. It's still unusual, but increasing. Cancer in the older population is increasing only because we have more and more older people.
Sure.
Right? So the incidence of cancer in the older population isn't increasing, but we have more older people. So that's good. But the more older people we have, the more cancer we're going to have.
Well, for the application of a cell or gene therapy, what's the triggering event where Symphony knows to get involved?
So the answer is we would like to get involved with all of these diseases as soon as a diagnosis is made.
Okay.
We really think we can offer value from day one, whether a patient needs treatment for their cancer, we can help direct what center of excellence might offer value. We can help direct the care that's delivered in the community. We know that an evidence-based approach to cancer is what gives the best outcomes and is also, interestingly, most cost-effective for the insurer. So we work very hard at Cancer Care to make sure patients are getting evidence-based care. We work with their providers collaboratively to make sure they get optimal treatment. So if a patient has already had a cancer diagnosis, already getting treatment, we can still offer value because frequently patients with cancer don't need one line of treatment. They need 2 or 3 or 4 so we can get involved in subsequent lines of therapy.
Okay.
But the sooner we get involved, the more value we bring. Same sort of thing if a patient has kidney disease, if we can get involved, if Renologic can get involved before they start dialysis, that's where we offer the greatest value, because in fact we have the ability sometimes to prevent the need for dialysis. But in fact, if a patient crashes onto dialysis, it means they haven't been prepared for dialysis. That's very morbid for the patient and very expensive. If we get involved early before the patient start dialysis, we can either help manage the patient and avoid dialysis or delay dialysis, but more importantly, make sure the patient is prepared for dialysis.
Okay.
We can also sometimes offer that patient what we call preemptive transplant. We can occasionally transplant patients even before they start dialysis. And when we're able to do that, that's the greatest gift we can give a patient.
Yeah, absolutely.
Right? If a patient gets transplanted with kidney disease before they start dialysis, they have virtually a normal life expectancy. If a patient has been dialyzed just a few times and then gets a transplant, they'll do well, but they still have a decreased life expectancy.
So how do we get out in front and identify the right candidates for the preemptive transplant? Because it does sound like the best pathway if possible, but is it a lack of supply of donors? Is it a difficult to identify appropriateness?
All of the above.
All of the above.
But again, if you have a 73-year-old man with hypertension and diabetes, a frequent scenario when you go into kidney failure, that patient, that individual isn't going to be a good preemptive candidate. Still doesn't mean they shouldn't be managed optimally and prepare for dialysis, right? But when you have a 23-year-old or a 32-year-old man or woman who carries a disease that causes kidney failure, those are optimal candidates for preemptive transplant. And sometimes people don't think about it. Their physicians don't realize preemptive transplant is an option. But in fact, if you properly and optimally manage your pre-dialysis community, sometimes as many as 10 or 15% of your transplants can go into a preemptive recipient.
Interesting. Okay.
So, but that's a very sophisticated approach, which we bring under the Symphony umbrella. And that's when we combine the expertise in managing kidney disease and dialysis that Renologic has with our experience for decades in offering the best in transplant.
Okay.
So this is sort of how it all integrates and how it all makes sense to bring these four apparently disparate programs.
Yeah, I was going to say, how do they dovetail? It makes sense how you're describing it. And then are there other disease states that eventually might roll into your suite of services as well, or this is the core focus for
This is the core focus right now. Is it possible that over time there'll be other offerings that our clients ask us to incorporate under Symphony? We're certainly open to that, but we're just releasing Symphony to the market now. We've just started to sell this product.
Is this something
we've just identified our first client? We're very happy about it.
Hey, we'll celebrate. So do you think, is this something that can be rolled out midstream? Does it have to be on effective date for the plan? Okay, so you could pick it up midstream today and roll it. Okay.
Absolutely.
So why don't we do this? We've been talking about an hour, so I usually like to zoom out and talk big picture again. So we got off in a couple different interesting tangents, partially my fault, but I love it because these are the type of questions that you don't always get from short sound bites. You have to have long form discussions to really understand what we're talking about. But I'll go for you first, Carolina. Big picture of healthcare. You said you recently got introduced to the being a patient, right, or understanding the interfacing with healthcare, not as a physician. As you think about where our system is moving and some of the big problems that we have to solve within the U.S. healthcare system, like what do you think the next few years are going to look like for us? And are there any big changes that you perceive to might be on the horizon for us? And that's a lofty question to ask, but I like to go that way and just kind of think about what the future state of our industry might look like.
I wish I can say something positive, but I think it's going to look really,
if it's okay, negative,
really messy before it straightens out. Because I think right now we're not in an ideal situation. We don't have an ideal system that supports one big lump of money to be paid upfront for a product that we have so many ethical questions, safety, efficacy, accessibility. So I think we're going to struggle a lot between the right decisions.
Okay.
But I don't doubt, like in the past, that we will be able to adapt. And from the manufacturer perspective, from the medical hospitals, and also from the support that, for example, our program can provide, will make a difference. Because gene and cell therapy are staying. They're not
you
going
think they're
anywhere.
gonna stay? Okay.
Absolutely.
Well, do you think, though, even if it's messy for a few years as we get more precise with the technology, is this truly a revolutionary? Do you think this is the beginning
Yes.
of a revolution in medicine?
It is.
Interesting. I'm an optimistic guy by nature, so I have to ask that question. But it may not be immediate that we see those positive effects, is what you're thinking.
Correct.
Okay. What about you, Oscar? What's your kind of future outlook on healthcare?
I think America, the United States, is clearly the most innovative country in the world with respect to healthcare. I think there are challenges, however. I think healthcare has become too political. I don't happen to believe a one-payer solution is the solution, but I don't think the way it's evolving is the answer either.
Yeah.
Right now, healthcare is consuming 18, 19, 20% of our GDP. Shouldn't consume that much. But right now, with the advances of cell and gene therapy and other drugs for other diseases, it's projected to consume significantly more than that. It's possible healthcare over the next 2 decades may consume as much as 30 or 35% of our GDP, and that's not sustainable.
No, it's not.
We can't educate kids. We can't put a military. We can't clean streets. We can't have schools if healthcare is the only thing we fund in an unchecked manner.
Yes.
So what we're doing from the perspective of the patient is spectacular, but it doesn't help if it's so expensive we can't deliver it to the patient.
Exactly.
So I don't know the solution. I know what we're doing now is not the answer. And we have to ask questions that we're uncomfortable with.
Yep.
In Britain, they have something called NICE, which determines on a quality adjusted life year value whether a drug should be put on the national formulary, because Britain's national health, right? So a drug goes through a 2-step process. First, it goes through like an FDA approval process, but then NICE looks at it and says, can we afford to put this drug or this gene on our national formulary?
I see.
Are we getting value from it? Right? If we say a quality adjusted life year of a patient is worth $50,000 and it costs $200,000 per year for this drug, we're not going to put it on the formulary.
Yeah.
Now, we don't ask, or we don't obviously ask those kinds of questions here.
Yeah.
But we're going to have to be able to start asking some of those questions. They're very uncomfortable questions. They're not consistent with some of the standard values that we have in America, where life is sacred.
Yeah.
But when life costs $20 million to prolong it for 7 years, is that a good expenditure? But we're heading in that direction.
Yeah.
So I'm optimistic in that these treatments, these therapies we're evolving are absolutely revolutionary. But we have to be able to afford them, or they don't do anybody any good.
I heard that position, and I can't remember this gentleman's name, but the rhetorical positioning of it was really fascinating. I think he posed the question is this: would you rather live in a world where these cures exist but we can't afford it, or live in a world where they don't exist at all? And both of those, both of the answers are, I don't know, but neither one of them is perfect.
Right.
So I think the model you're describing in the U.S. is they exist, but we're having difficulty affording them. But at least they exist, and for the individuals that receive them, they might have life-saving or lifelong lasting positive effects. But there's a price tag associated with it too.
Right.
So neither way is necessarily sustainable either.
No.
And I question the sustainability. I think the average family premium is somewhere in the $24,000 a year range. You mentioned the $4.5 trillion problem we have in healthcare.
But even for government, because for sickle cell, a lot of these patients are in government programs.
Okay.
Or 60% are disabled. And you have states where there is concentration of population that suffer from sickle cell. So how Medicaid is going to do this?
To pay, yeah.
Or how Medicare will do with diseases that are from the older population, and they will have a gene and cell therapy product. So it's not only the self-funded. I mean, I think everybody's impacted.
I mean, we are outstripping our ability to fund some of these advances. So we have to ask the uncomfortable questions, and after we ask that, we have to answer these challenges as well. If we're going to be able to continue to make progress, to continue to offer opportunity to patients who currently have no hope, right? But we have to be able to afford them.
Yep. Well, let's end on a positive note then, because we definitely all kind of presented this as a little bit of a doom and gloom scenario, myself included. I'm suspicious of how we resolve these things. But if you're a listener here and going, that was a really interesting podcast, but what is one or two things you would want to leave somebody with to go about their day or to be thinking about? I'm curious.
Yeah, please. Well, I mean, the obvious is what we've been talking about. People who 2, 3, 4, 5 years ago were incurable and had very limited life expectancy can now frequently look forward to normal life expectancies or near normal life expectancies, robust health, good quality of life, the ability to go to school, because a lot of these diseases affect very young adults, ability to go to school, get married, have kids, have productive and meaningful lives. That's spectacular. It's progress we couldn't have envisioned decades ago. So that's amazing.
What about you?
I think for me, I will go back to what we were talking about, education. I am very proud of the program that will allow to provide information and educate every stakeholder to what it is new, what is common, how to handle things. And I think that's going to make a difference in a lot of people and payers. And as I said, everybody that is involved. So
I hope you're right. I think you are right, probably. I think we will figure it out like we always do. You mentioned innovation in the United States. There is a spirit, I think, here that we're going to figure these things out come hell or high water, and I think we will, but it probably will look messy for a period of time as well. But I look forward to whatever comes out as a result of that. So thank you both for you traveling in particular, and thank you for coming up from Dallas. Heidi's off camera, but thank you, Heidi, for putting this together and being a great partner with Pareto as well. I can't say I appreciate you guys anymore because this was a really cool subject, and I think the listeners are going to get a lot of value out of it as well. So thanks for your time.
Thank you very much for having us.
My pleasure.